I'd like to welcome you again. After studying the normal anatomy of the liver, it is a time to see some of the pathologies and some of the hepatic focal lesion. Let us start with the first slide. This is an example of simple hepatic cyst. Why it is simple and why it is cyst? Because it has a well-defined wall. It is totally anechoic. It is totally black, and there is definite posterior enhancement behind the cyst. This rectangle is hyperechoic, more whitish than the other parts of the liver, so there is definite posterior enhancement behind this focal lesion, so mostly it is a simple cyst. Let us see the video. And obviously this is the middle hepatic vein, and this is the left portal vein, the umbilical portion of the left portal vein. So expecting that we will see here the ligamentum venosum, and expecting to see here the IVC, and this is the middle hepatic vein going to the IVC. So let us see this video. Yes, this is the middle hepatic vein, and this is the left portal vein, and this is the IVC, and this is very nicely seen ligamentum venosum. So this is a ligamentum venosum communicating or going from the left portal vein to the IVC. And here this is the IVC and the origin or the insertion of the middle hepatic vein inside the IVC. So this is the ligamentum venosum, middle hepatic vein. Here the segments of the liver is segment 1 between the echo endoscope and the ligamentum venosum, which is the caudate lobe, and segment 4A in between the ligamentum venosum and the middle hepatic vein, and segment 8 behind or next to the middle hepatic vein. So let us see the video. Yes, this is the IVC, and this is the ligamentum venosum, and this is the middle hepatic vein, very nicely seen. Yes, middle hepatic vein, ligamentum venosum, and this is a cyst located in the segment between the ligamentum venosum and the middle hepatic vein, which is segment 4A. This is segment 1, caudate, 4A, and 8. So this very nicely seen simple cyst is in between the middle hepatic vein and the ligamentum venosum. So it is located in the in segment 4A, and it is a very simple cyst. I think very benign, innocent cyst, because there is no solid components inside and there is no turbid fluid inside. It is totally anechoic with definite posterior enhancement. Let us see this video. Yes, this is another simple cyst. Now the echo endoscope from the middle hepatic vein, we do anti-clockwise rotation to go to the left hepatic vein. So when you see the middle hepatic vein, you can do anti-clockwise rotation to see the left hepatic vein. So, and this is the left hepatic vein, and this is a small cyst, and segment 2 is above the left hepatic vein, and segment 3 is below the left hepatic vein, and this is the left portal vein. So this is the left hepatic vein, left portal vein, segment 2, segment 3, and this lesion is located in segment 3, and it looks like a benign cyst, simple cyst, because there is posterior enhancement here. It is totally anechoic, no internal echoes at all, black, jet black, with a definite wall. So this is a very here simple cyst, and this is the left hepatic vein, and segment 2 and segment 3. Okay, let us see the next one. This is a small cholangitic abscess in a patient with obstructive jaundice. So again, this is the inferior vena cava, middle hepatic vein. It is a homogeneous, has a homogeneous diameter, the same diameter. It is a long vein going deep inside the liver with homogeneous diameter, and finally going to the IVC, and this is the ligamentum venosum, communicating the inferior vena cava to the left hepatic vein. Okay, there is here a very nicely seen small abscess. Small complex cyst. Abscess is a complex cyst. I can't swear that is an abscess, but when we see a complex cyst in a patient with fever and rigors, then you should suspect abscess, especially if it is complex cystic. So this is a small complex cyst in a patient with actually obstructive jaundice. Okay, and this lesion is between again the ligamentum venosum and the middle hepatic vein. So it is located in segment 4. This is segment 1, caudate lobe, and this is segment 4, and this is segment 8 below the middle hepatic vein. Okay, let us see this large focal lesion, complex cystic, with soft tissue shadow inside and peripheral fluid. Looks like an abscess, and actually the patient has fever and rigors, so the most likely diagnosis is a liver abscess. Yes, now very nicely seen the left hepatic vein. Yes, this is the left hepatic vein. Yes, this is the left hepatic vein. Go back a little. Yes, this is the left hepatic vein. Yes, with dilated biliary radicle. So this patient has obstructive jaundice, and these are double barrel sign, branch of the portal vein and branch of intrahepatic biliary radicles. Okay, and this is a large complex cystic lesion, and these two ducts parallel to each other, dilated biliary cistern, dilated biliary radicle, and one of the portal veins, because they run parallel to each other. In normal, I can't see intrahepatic biliary radicles because they are slit-like or collapsed, but when there is obstructive jaundice, they dilate and give us this sign. And this is a large complex cyst inside the liver in the patient with obstructive jaundice with fever and rigor, so it is a large abscess. Here I can do fine needle aspiration to be sure that is an abscess and to obtain some fluid for culture and sensitivity. And here we can do we can put a double pigtail stent between the gastric lumen and the abscess cavity, exactly like cystogastrostomy in large abscesses. We can do that, but we can do also fine needle aspiration, aspirating some of the material to prove that it is an abscess, and to do culture and sensitivity and giving antibiotics. This may work well with small or moderate-sized abscesses, but in cases of large abscesses, there are some case studies about about putting a double pigtail stent between the abscess cavity and the stomach, exactly like cystogastrostomy. This is another nice case. Here this is the left portal vein. By anticlockwise rotation, we can locate the left portal vein very nicely, and the segment above is segment 2 and segment below is segment 3, and this is the left copula of the diaphragm. And here we notice that there will be a large mass. This mass is centered between segment 2 and segment 3. Part of the mass is in segment 2 and part of the mass is in segment 3. This mass is, yes, this is the left lobe, segment 2 and segment 3. This mass is very large mass, as we will see later, and hyperechoic. Yes, starting here the mass, hyperechoic, mostly homogeneous with some areas of hypoechogenicity. And here very nicely we can see the fish eye appearance. This is the umbilical portion of the left portal vein. And here to the left side of the screen and going to the umbilical portion of the left portal vein, this ligament is ligamentum teres. And here expecting ligamentum venosum. So the fish eye appearance, which is the umbilical portion of the left portal vein here, and to the left of the screen is the ligamentum teres, and to the right of the screen is the ligamentum venosum. Here this is the ligamentum teres. Segment above is segment 3 and below is segment 4B. So this lesion occupying segment 3, yes, and segment 2 in the previous view, and also extending to segment 4B. So this very large lesion occupying segment 3, 4B, and 2. This is about 10 or 11 centimeter. Hyperechoic in a patient with very good general condition. So mostly it is a large hemangioma, large cavernous hemangioma. Yes, the big vessels are arranged along its periphery, while inside we cannot observe hypervascularity because here the flow is very low flow. So the main vessels is arranged along its periphery, maybe a feeding vessel, but inside the tumor or inside the mass, the benign mass is very low vascularity. So in CT with contrast, in the arterial phase, there is just beading or filling of the periphery, because there is very low flow. And in the venous phase and late phase, there is increase in the uptake from the periphery to inside the closed iris sign. And in the late film, there is complete filling of the mass. So this is a classic cavernous hemangioma. Located in segment 2 and 3, the liver, and segment 4B. And here there is another smaller one, another small hemangioma is very nice. This is very nicely seen fish eye appearance. This is the umbilical portion of the left portal vein, and here this is the ligamentum teres. And here is the beginning of the ligamentum venosum. So it is located in segment 3. Here is segment 3, and here is segment 4A, and all that is segment 4B. And this is the fish eye appearance, and this is a very large cavernous hemangioma and another smaller hemangioma. Hemangioma may be single, may be multiple, 2 or 3 or 4. It is known for its multiplicity in the liver. Let us go to the next video. This is a very serious lesion, multiple, hypoechoic lesions. Yes, this is a focal lesion. This is a smaller one. This is multiple hypoechoic lesion. Yes, and this is the left hepatic vein. So they are present in segment 2 and segment 3. This is classic metastasis because it gives what is known as a bullseye appearance. There is a peripheral halo. You notice that the center is more hypoechoic than this peripheral rim. There is a peripheral rim, slightly hypoechoic. So this picture goes with liver metastasis. They are present in segment 2 and segment 3, and this is the left copuloid diaphragm, and this is the heart. And here this is the fish eye appearance again, the left portal vein, and also there are focal lesion throughout the liver, and this is the intrahepatic portion of the IVC. Here segment 1 is the caudate lobe in between the echo endoscope and the intrahepatic portion of IVC, and below is segment is 4A. And this is the aorta. So these are multiple hepatic focal lesions in nearly all segments of the liver, highly impressive of liver metastasis. And there is here in endoscopic ultrasonography, there is a very good option, which is the elastography. Elastography is a software to determine the consistency of the mass, whether it is soft or firm. Depends on the deformability of the mass. This small mass is supposed to be compressed by a big vessel, pulsations of a big vessel, or by pressure by the echo endoscope, or pulsations of a nearby vessels. So in relation to this compression, the lesion distorts. If it distorts markedly, having high elasticity, then it is mostly a soft tissue. But if it does not change its shape in relation to compression, is not deformable, no elasticity, then it is hard and colored by blue. But if it is soft, it will be colored by red, yellow, and green color. So this is a focal lesion here. We can apply elastography. Yes, I can apply the software of elastography. Yes, very nicely, very accurate, really, in the liver. It is very accurate in the liver, more than in the pancreas, because in the liver, it compares with a very solid lesion with the normal soft liver. So the difference is marked. So this is clearly, it is a blue color mass. Yes, this is the screen divided into half, the same view, but it divided into half. This is a mass, and this is the same mass. This the picture is the same picture is like that. So this mass appearing very clearly colored with blue color, while the normal liver around is colored by soft green. So if it is a very hard mass, highly impressive of liver metastasis, here we can apply, this is a qualitative technique, but we can do what is known as strain ratio. This is a semi-quantitative by comparing the elasticity of the mass and a control point outside the mass. The control point here will be the normal liver. So this circle measures the elasticity of the mass, which is not elastic, it is hard, and comparing it with the soft liver. So the difference is 23 is very high strain ratio. This is the strain ratio. Very high means that it is a hard mass favoring the diagnosis of serious, solid, malignant mass. And thanks for your attention.